Welcome back, students, to another session of our Explainer series for the Decode Healthcare Masterclass. I'm your lead instructor, Harshal, and today we are breaking down Part 118. We're doing an advanced surgical DRG deep dive into Major Diagnostic Category 22, surgical burn procedures and skin grafting. We are taking the macro-level theories of inpatient grouping that we've been talking about, and we're applying them directly to the incredibly complex, high-stakes clinical mechanics of burn management and surgical reconstruction. But before we jump in, a quick reminder from our course material. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. All right, here is our roadmap for today. 1. MDC 22 surgical hierarchy. 2. High-volume burn DRGs. 3. ICD-10 PCS precision. 4. Root operations deconstructed. And 5. CDI and audit defense. Let's get right into it with Section 1, Overview of the MDC 22 surgical hierarchy. Think of this surgical partitioning logic in burn management as a very strict gatekeeper. It is incredibly sensitive to clinical intervention. A patient might be admitted with a primary medical diagnosis of severe third-degree burns, right? But if an emergency surgical decompression, like an escharotomy or early excisional debridement, is performed in a formal operating room setting, boom, that procedure instantly overrides the medical diagnosis. The entire case gets thrust into a surgical DRG. The clinical spectrum here is just vast, ranging from those emergency decompressions to tangential excisions, all autologous skin grafting, and even complex reconstructive flap procedures. Because these interventions eat up massive clinical resources, accurately capturing that jump from a medical to a surgical partition is literally the absolute foundation of MDC 22 coding. So the DRG grouper engine ranks these surgical interventions using a very specific step-down logic. At the very top, we have extensive burn with an OR procedure. This captures those massive, catastrophic traumas that require intensive surgical resources. Moving one step down the hierarchy, cases are classified as non-extensive burn with skin graft, which covers procedures like split thickness or full thickness autografts. And right below that sits non-extensive burn with other OR procedures. This lower tier often captures preliminary wound bed preparations, like a fascial excisional debridement done without immediate skin graft coverage. Grasping this exact step-down logic is critical, folks. Why? Because capturing a skin graft versus a non-graft procedure dictates a completely different payment family for the hospital. Moving right along to Section 2, High-Volume Surgical MDC 22 DRG Families. Once we lock in that base surgical DRG, say MSDRGs 928 through 930 for non-extensive burns with skin grafts, our secondary diagnoses step in as massive financial levers. Let's say a patient is recovering from a split-thickness skin graft and has an uncomplicated post-op course. They stay right at the base DRG weight. But if a complication like acute tubular necrosis develops and is clearly documented, it acts as a complication or comorbidity, a CC, which elevates the severity and the reimbursement. Now, if the patient develops something like profound burn wound sepsis or total graft failure, that qualifies as a major CC or MCC. An MCC pushes the whole encounter into the highest possible payment tier, which is essential because it accurately reflects the immense clinical resources required to stabilize a critically ill burn patient. But watch out, guys, because coding complex burn traumas comes with a major hazard, the POA drop. If a severe condition develops after the patient is admitted, it gets documented with a present on admission indicator of N. And in many cases, that completely prevents the condition from increasing the DRG payment. So if a severe surgical site infection develops on the donor site of a skin graft, or a patient has a post-op hemorrhage that needs a blood transfusion, those are treated as hospital-acquired conditions. Payer networks heavily penalize these events. That means the hospital is not getting that higher DRG weight, despite the care costs going through the roof. All right, Section 3, ICD-10 PCS precision, CDI, and audit defense. Now let's shift gears to procedural mechanics. The ICD-10 PCS system demands absolute, pinpoint precision, especially inside body system 0H, which covers skin and subcutaneous tissue. As we know, every code is built using 7 alphanumeric characters, but when we're dealing with burn surgery, that third character, the root operation, is the ultimate pivot point. Seriously, a single misunderstanding here changes the entire surgical classification. You have to flawlessly extract the objective of the procedure from the operative report. Whether the surgeon is taking healthy skin to use somewhere else, cutting away dead eschar, or applying a complex synthetic matrix, every single physical action requires its own highly specific root operation assignment in the PCS table. Here is a golden rule you absolutely have to master for burn grafting: the strict separation of donor and recipient sites. In autologous grafting, the surgeon harvests healthy skin from one part of the body to apply to the burn wound. Listen closely, that autograft harvest site must be coded completely separately from the recipient application site. The harvest is coded as an excision of skin at the donor site. Applying that skin to the burn wound is coded under a completely different root operation. If you mix these two distinct surgical sites up, or if you forget to code the harvest entirely, you drastically underrepresent the scope of the surgery, which leads directly to failed audits. Next up, Section 4, Root Operations Deconstructed. To truly nail MDC 22 cases, understanding the difference between excision and replacement is foundational. Excision means cutting out a portion of a body part without replacing it. In the burn world, this perfectly describes tangential or fascial excisional debridement, where the surgeon is just cutting away devitalized burn eschar to prep a clean wound bed. Replacement, on the other hand, means putting in or on biological or synthetic material that physically takes the place of a body part. So, applying the actual skin graft to that wound bed, that's a replacement. Confusing debridement with grafting by picking the wrong root operation will instantaneously trigger a DRG mismatch. Now, things get a little spicy when we move away from traditional autografts. Modern burn care heavily relies on synthetic grafts and cellular or tissue-based products, which we call CTPs. When a non-autologous substitute or a synthetic dermal matrix is applied to a burn, it is still coded as a replacement. However, you have to carefully select the 6th character of the PCS code to denote the exact type of device or tissue substitute used. Figuring out if it's a synthetic graft, a xenograft from an animal, or an allograft from a human donor means you've got to meticulously read that surgical implant log. When we apply that replacement root operation to traditional grafting, we have to identify exactly how much tissue is taking the place of the burn wound. A split-thickness skin graft, or STSG, involves transplanting the epidermis and only a portion of the dermis. A full-thickness skin graft, or FTSG, transplants the epidermis and the entire dermis. We often see these used for restoring high-function or high-cosmetic areas, think face, hands, feet, or major joints. The PCS codes will differentiate between the layers of skin and subcutaneous tissue being replaced, and that directly informs the severity and expected recovery modeled by the DRG. Another absolutely vital root operation in acute burn management is release. The definition is freeing a body part from an abnormal physical constraint. This is exactly what we use for a surgical escharotomy. Imagine a patient with circumferential full-thickness burns on their arm or chest. The rigid, burned eschar basically acts like a tourniquet, causing acute compartment syndrome. The surgeon has to slice through that eschar to release the pressure and restore blood flow or breathing. The golden rule here: the procedure is coded to the body part being freed, like the arm or the chest wall, not the eschar tissue that was cut. Finally, we arrive at Section 5, CDI and Audit Defense. This is where the rubber meets the road. Integrating these rules into clinical documentation improvement is literally how hospitals survive aggressive payer audits. Burn cases are massive audit targets. A huge defense strategy is proving an operating room level of care. Payers love to send denials claiming a debridement was just a bedside dressing change, rather than a formal surgical excisional debridement. The documentation must explicitly detail the use of anesthesia, surgical instruments, and excision into viable tissue. And don't forget, failing to document the total graft surface area coverage in precise square centimeters can lead straight to downcoding. Vague documentation just translates to undefendable claims and revenue clawbacks. So, how do we empower our CDI teams? By actively validating those correct root operations and firing off queries when the surgical narrative is fuzzy. If an operative note just says debridement, query the physician. Was it tangential, shaving away layers, or a full fascial excision down to the muscle fascia? CDI specialists also need to query for exact surface area measurements if they aren't in the graft application note. Plus, we need crystal clarity on whether we're seeing normal expected sloughing of a graft versus actual clinical graft failure. True graft failure represents a highly weighted secondary diagnosis that we cannot afford to miss. So, I want to leave you with this provocative thought. Knowing the immense clinical and financial weight carried by major diagnostic category 22, and understanding how a single misunderstood root operation, or just one misidentified donor site, can completely flip a hospital's reimbursement and quality metrics on their head, how are you going to scrutinize the operative notes of your next complex burn trauma? I challenge you to look way beyond the surface of the text and ensure that every single nuance of debridement, release, and grafting is accurately captured in that final DRG. And that wraps up today's explainer lesson for the Decode Healthcare Masterclass. As our course material always reminds us, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Join us next time as we unpack Part 119, where we'll be shifting into an advanced medical deep dive of Major Diagnostic Category 23, Factors Influencing Health Status and Other Contacts with Health Services. Thanks for watching, and I'll see you in the next session.